everyone, and welcome back to the #See Arthritis event. And we couldn't be happier to be in the studio today following his great debate. Dr. Jaime Guzman, welcome to the studio, Dr. Guzman.
Uh, Thank you very much for the invitation, Sharon. Much appreciated.
And fantastic. I'm so excited to talk to you about your debate. It was on, as we talked before the recording started, a very, I think, interesting topic and one that people with arthritis are sort of starved to hear about. But before we dive into our conversation, Dr. Guzman, I'm going to tell our audience just a little about you. Dr. Jaime Guzman is a pediatric rheumatologist, so pediatric, think kids, and clinical investigator at BC Children's Hospital, and a clinical associate professor at the University of British Columbia. Dr. Guzman specializes in treating children with rheumatic diseases and leads research on juvenile idiopathic arthritis, or JIA, outcomes, including the National Registry CAPRI. His presentation, as I mentioned when at the start, is the what's known at the Canadian Rheumatology Association annual scientific meetings Great Debate. And the Great Debate topic or title was Be It Resolved that medication should be tapered in patients with inflammatory arthritis in remission. So here we go, Dr. Guzman. First of all, again, welcome to the studio. And I wonder if you can just take a minute or two to tell us about your own clinical practice, but also your area of research at BC Children's and Women's Hospital and at UBC.
Uh, yes, and it will be my pleasure to say a few words. And as you probably hear from my accent, I am originally born in another country. I was born in Mexico, but I've been in Canada for 30 years. And I started in Vancouver at the BC Children's Hospital in 2007. And since then, my practice has been basically focused on children with arthritis and other rheumatic diseases. And my research program focuses specifically in juvenile idiopathic arthritis. And this allow that focus in large cohorts. And these are collaborations across the country with many other pediatric rheumatologists in Canada. And we follow systematically children with arthritis and learn what is working, what is not working, how are they doing, which is very important information for families when they get a new diagnosis to know about. This is what is happening. This is what is current.
Yeah, and that's the Capri registry that I mentioned in your bio. I also, when you're spending your days working with children, treating children, you're also working with their families. It's not just treating the child, you're working in this incredible environment of family.
That is correct. And so basically we provide family-centered care because it's very important for families, for parents to all feel that they are in the same team and that they are supported as they go through a diagnosis of arthritis and different treatments over the years.
Yeah, I mean, as you well know, Dr. Guzman, live with rheumatoid arthritis, and it's sort of bad enough to be given that diagnosis as an adult. But to be handed that diagnosis of juvenile idiopathic arthritis as a child, the reverberations are felt throughout the family at a very deep level. So thank you so much for everything that you and your colleagues do. And I know you work closely with Cassie and Friends, who's that's a foundation that focuses on helping kids and families. So we're going to provide information about Capri and Cassie and Friends at the end of this interview, so that folks who are watching Dr. Guzman can learn a bit more about those things. Um, let's get to the meat of the matter. That's your debate. So, as I said, this is one of the things that happens is when you get put on medicine, the very first thing you start thinking about is when can I go off of it? Or when can I take less of it? So, the Canadian Rheumatology Association has this really fantastic way for interprofessional learning, and that's through this great debate format. So, you took the pro side of the argument or of the debate, favoring tapering medications in patients with inflammatory arthritis who are in what we call remission. So in medication-induced remission, I suppose you would call it. And then you had colleagues taking the opposite side, saying, no, 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 we should never taper, we shouldn't taper our medication. So give us a little bit about, give us a sense of the debate, how it went, and particularly the points that you argued for, which supported tapering or reducing, I guess maybe is a more lay-friendly term.
Yes. First, I have to say, as you mentioned, the debate is historically very well attended. And when you get up there, you see that there is a full auditorium. All your colleagues are there. And then you wonder, oh, where did I put my name to? Because there is often also a little bit of humor intertwined,
Sure.
jokes intertwined, which is a way of facilitate learning. And so basically, I was arguing the pro side together with Glenn Hasselwood. And so I spoke of the evidence in adults, and that will support a point of view. And I concentrated on the evidence in children.
Right.
And so basically, the main points are if you are giving the diagnosis of juvenile arthritis to a kid that is 5, 6 years old, 8 year old, are you gonna tell them that they have to be on medications for the rest of their lives?
Yeah.
That means 80 years? Well, my argument is no, you shouldn't do that because we know several things. We know that about half the children that are diagnosed with juvenile arthritis, by the time they get 18, they are fine without medications, meaning fine, no signs of arthritis, and no medication. So the chances are not too bad. This may be different with some of the types of adult rheumatic diseases because the way arthritis presents in children is different.
Right. So you say 50%, and is this for specific to juvenile idiopathic arthritis then that you're speaking of? Are there different types of juvenile arthritis? And does this hold true for them as well?
That is a very good question. Juvenile arthritis, meaning chronic arthritis of unknown cause that starts in children, there is at least 7 different types or categories of arthritis, and there are some that are only seen in children,
Right.
non-adults, and others that are analogous or similar to diseases seen in adults. And so the frequency of being off medications and in remission by the age of 18 varies according what kind of arthritis do you have. Um, if you have something called systemic AIA, characterized with fevers at the beginning and rash, actually your chances are better than 50%. They are close to 80%.
Wow.
If you have, on the other side, rheumatoid factor positive, anti-CCP positive, meaning arthritis that has these antibodies in the blood, then your chances are probably less. It's
Okay.
still not zero, but maybe 30%, maybe 20%.
And for our audience, Dr. Guzman, arthritis in kids is very different than arthritis in adults. Explain some of those differences to us.
So one of the differences is that some types of arthritis only happen in children. That's
Right.
one difference. But the other difference is the amazing ability of a young body, a child, to heal and to re-educate the immune system. And so those two are very important key difference in how arthritis manifests and how it is expressed in children versus adults. There are some types of arthritis that only happen in children, and that they are very common before the age of 5 years old, and then kind of disappear, not to be seen again as you grow older. And so that's what makes the difference. The types of arthritis, but also the ability of the children's body to heal and re-educate the immune system as it is developed.
Amazing. So back to the debate. You argued for this, the pro side, and you've given some of those reasons. You had colleagues arguing the opposite. Share with us what their views were, if you might.
Well, the views were the significant risk of flare and the risk of a flare-up of arthritis depends on the kind of arthritis that you have. If you have ankylosing spondylitis as an adult, or now called axial spondyloarthropathy, or if you have rheumatoid factor positive, anti-C positive arthritis, rheumatoid arthritis, their argument was in those diseases, if you require biologic medications to control them and you stop the biologic medication, the chances of flare are very high, 70% or thereabouts. And so that was one of their key arguments. Our counter argument is, particularly in children, those types of diseases are actually less frequent. The more frequent type is a different, and the chances of a flare, even though it's still is still a possibility, are significantly less.
Yeah. So, in actual fact, the con side had pros to offer for not tapering. I mean, they were, from an evidence perspective, they're correct, but you were also correct from the kids' perspective. What did the vote say?
Oh, we won. We won.
Oh! Are there that congratulations, by the way. So I understand physicians, adult rheumatologists who treat adult inflammatory types of arthritis may hesitate to reduce lower taper medicines because of these factors that you mentioned, rheumatoid factor, high CPP. But are there adult patients where you think it might be possible? Did they offer that evidence?
Yes, and in fact, if you read some of the guidance provided by the Canadian Rheumatology Association, the recommendation is to have a conversation,
Okay.
with parents that have rheumatoid arthritis and about the pros and the cons. This is not something that the physician should decide and impose on a patient.
Yeah.
This is something that should be discussed. And I agree with that guidance. It should be discussed. And there is kind of two important considerations. One is if you are able to stop it and remain well, that's fantastic.
Yeah.
And it can happen, although the chances are not too great. But the second one is even if you don't manage to stop it entirely, if you manage to reduce to about half the dose or double the frequency, then you can treat two patients for the price of one,
Uh,
meaning the resources across the country, across the provincial services go further.
yeah. So that's a societal benefit.
Societal benefit, yeah.
Yeah. Yeah. That's a really important point and not necessarily one we as patients think about, but we certainly do as a taxpayer, right? As someone who has to contribute to the monies that go towards paying for healthcare. Um, if you if you were to say why juvenile idiopathic arthritis is different. So why is it that in half of the people you are seeing in your kids' clinics can taper and stop and their arthritis basically goes away? It's not playing a role in their lives as adults. Is it is it because do you catch arthritis in kids earlier? Are you able to treat it? Because we know there's this window of opportunity. Are the things we talk about in adult arthritis, Dr. Guzman, true in kids? If you treat it early and suppress it early, you could maybe stamp it out entirely. Is that what's going on in kids' arthritis? Or is it because they're different disease processes altogether?
I think two answers are partially right.
Okay.
One, there is at least a couple of types of juvenile arthritis that you don't see in adults.
Okay.
And those types, in a certain proportion of people, even before we had biologics, even before we had effective aggressive treatments, we knew it happened. That for some kids, just the type of arthritis that affects them can actually go away.
Okay.
Now, the second thing is, and this the best example of the second issue of addressing early diagnosis, early treatment, the best example is systemic juvenile arthritis. Systemic juvenile arthritis uh, was first is also known as Still's disease,
Right. Okay.
and it is a disease that has been recognized in children since the end of last century. Uh, And basically, before we had effective treatments, many of them end up with significant disabilities, significant deformities, short lives. Now, in that particular type of juvenile arthritis, early directed treatment has made a substantial difference.
Okay. Okay.
A substantial difference to the point that, as I said, 80% of them, by the time they get to adulthood, the disease is gone. And it is not because it usually does it. It is because the treatments applied early make it go away.
Amazing. That's amazing. I guess it speaks sort of about the importance of early identification of disease, both in kids and adults, right? It's getting on top of it early that can make a significant difference. We're going to close our time together. I could talk to you for hours, Dr. Guzman, and I know you've got patients to see, so I don't want to shortchange their time with you. Well, let's close with the theme of the meeting this year is shifting tides, embracing change in rheumatology. So, as you've told our audience, you've been in rheumatology for quite a few years, though you only look 39 years old. It's amazing how long you've been practicing and you still look like a baby. Um, what have you seen? What have been the shifting tides? And what do you see on the near horizon line in terms of change for kids in arthritis in particular?
Um, there is challenges, but I also see opportunities.
Yeah.
And one of the challenges for kids is medication coverage.
So
Um,
reimbursement, meaning who's going to pay for it?
Exactly.
Okay.
Insurance coverage to pay for medications because many of these medications, as you know,
Very
are
expensive.
so expensive that a family really couldn't afford to pay for them out of pocket. So one of the challenges that we face in juvenile arthritis is that there is only coverage for a small number of medications. Adults have access to many more medications than kids do. And this is because, it's a small market share, companies are not very interested, the trials are not done, Health Canada doesn't get an application to kind of use the medication in children. It doesn't happen.
They don't come in the right doses for kids.
Exactly. Then, you need the studies to show what is the right dose, but also often regulators ask for trials specific in children before they agree that that medication can be marketed to be
Yeah.
used.
Yeah.
So that's one of the challenges that we will are facing and we will continue to face for the foreseeable future is access to those medications. The second challenge that is very important is as important as medications are, they are not the whole picture.
Right.
They are not the whole picture. And so what we need is better ways of improving the quality of life of children with arthritis. This means better pain control over time, better interventions to make sure that they are as active as they need to be to develop their muscles, their bones, and grow. And um, also, very important that they learned that despite the arthritis, they can have full, healthy lives, and that they should pursue their interests. They should try to get into their careers that they want, try to kind of, form a family, whatever they want to do in life. And that requires some active intervention because sometimes many people feel kind of obviously depressed
Yeah.
with a diagnosis of arthritis,
Yeah.
felt that they are not able to do things because of the arthritis, and that can be very hard in a child because that can get into your mind as well. And then you start seeing yourself as my options are this much. But we need to expand that.
Yeah, I mean, it's arthritis can be a very isolating diagnosis, and I can only imagine that is amplified in a child when you don't necessarily have your brain isn't fully developed. So
Develop.
you can't reason through some of these things that perhaps you can as an adult, though it affects adults that way as well. Dr. Guzman, I just sit here and I'm amazed at we've only scratched the surface at your level of expertise and knowledge, but we're so grateful that you've taken the time to sit with us and talk about the debate, but also about, what the differences are between adult arthritis and arthritis in kids, and that it's very different. Some of the challenges. If you were to send our audience away with one uh, happy thought about arthritis, what would it be?
Right now, despite these challenges, we are at a stage that you cannot tell when a kid has arthritis. Basically, unless you ask, most of our kids are having healthy lives, doing whatever they want. That's a happy thought. It is very, very, very rare that we see anybody who physically has the signs of arthritis in children now, which is great to see.
Well, you just made my heart want to burst out of my chest. And my tears are welling up in my eyes. So it's a perfect chance to get off camera. Thank you so much, Dr. Guzman, for taking the time to sit with us. We're so appreciative, and we wish you the very best in your work and in the great caregiving that you provide to kids and families. We appreciate you very much. As I mentioned, we'll give information about Capri, about Cassie and Friends, and anything else you'd like us to share via the websites. We would certainly be happy to do that. So thank you very much. And we want to thank our audience for joining us in this hashtag C Arthritis event interview, and especially you, Dr. Guzman. So we'll see you again soon, everyone. Take good care.
Thank you very much.